for the prevalence of malnutrition, you'll see that malnutrition at diagnosis is anywhere from 6 to 50% of the children at diagnosis. That's such a huge variance there in those percentages, and primarily it's because there is no definition, a definitive definition for malnutrition. A lot of institutions use different parameters to define malnutrition. Again, the variance varies a lot during therapy, for anywhere from 8 to 32% at sometimes during their treatment. Oncologic factors that are associated with malnutrition is the type of tumor. So we know the head and neck tumors, that's going to be your CNS tumors. Your diencephalic syndrome, that may include the hypothalamus and the optic chiasm. And then, of course, treatment. The patients that are going to undergo surgery, which is the majority of your CNS tumors, they're going to undergo radiation, which can also affect their nutrition status, bone marrow transplant, and then, of course, the frequent intervals of the chemotherapy. So about the time they get the chemotherapy, they're nauseated, get through the chemotherapy, their counts drop, they don't feel like eating, and then it's time for the next course of chemotherapy. So that contributes quite a bit. And then, of course, the demographics. Some other factors that while you're going through treatment that can affect the nutrition status is the mucositis. Again, about the time you recover, it's time for chemotherapy, and then the mucositis rears its ugly head again. Constipation, the diarrhea, gastritis. We have the nausea and vomiting, and the anorexia. The next few slides I'm going to talk about just treatment and things that you can do to help kind of curb some of these side effects. And also with the understanding it's not just during treatment, talking to patients after treatment of their brain tumors, they also have to deal with a lot of these side effects. So the nutrition during the treatment. So some strategies for mucositis is just doing oral rinses with water, sports drinks or juice. We don't recommend any carbonated beverages. And we also recommend the sugar-free candy, which aren't always easy to find, but it seems like the sugar, the ones with the real sugar in them, actually make the mucus more sticky. We try some aromatherapy. We actually use some little wands with aromatherapy in there, maybe lemon, peppermint, ginger, those different flavors. And then, of course, adding gravy, moist soft foods, butter, things like that to the food. When all else fails, we'll support them with IV fluid or some IV nutrition. For the constipation, the high-fiber diet, as is important as the high-fiber diet is the increase of fluid intake. You have got to get the fluid intake, otherwise you've got fiber just sitting in the bowel, not going anywhere, that can compound the effects. Avoid caffeine. Caffeine tends to make the intestines constrict, which also exacerbates the constipation. Prune juice is a good, cheap, readily available option for constipation. Then, of course, the doctor will prescribe the stool softeners or laxatives. For the diarrhea, I think probably everybody going through chemotherapy at some point has experienced some diarrhea. Again, you want to try to increase the fluid intake, limit sugar beverages. The sugar can have an osmotic effect and pull water into the intestines. You want to try to increase your sodium and potassium intake if possible. And a good kind of rule of thumb is for every episode of diarrhea to try to drink at least a half a cup to a cup of water to try to stay hydrated. Not always possible, so then we would have to actually do some IV fluids or IV nutrition at that time. So the nausea and vomiting, thank goodness for supportive medicine. We've come a long way with the antiemetics, but some other little tricks you can try even after treatment is to do cold foods or room temperature foods. You always think of the cartoon with the little drift of aroma coming up, and that is very nauseating to a patient who's already nauseated. You can try liquids between meals. I wouldn't recommend eating a meal and then drinking a bunch of liquid right after that. It's kind of like a reservoir in the stomach, and then it's going to take the path of least resistance and come up quickly before it goes down. Ginger ale seems to help. Salty crackers can help. Also, I would avoid lying down after eating. Try to stay up for at least 30 minutes to an hour. And then anorexia, that seems to be one of the problems too that can continue just throughout the trajectory of the treatment. So we try to encourage just little mini meals, try to make them count with protein, peanut butter, cheese, those sort of things that don't have that high aroma. Limit foods, limit the fluids with the meals, kind of the same thing with the diarrhea. avoid strong food orders, try oral supplements. There's, try to get creative with some other, homemade remedies, flavor additives, and actually exercising can help actually burn some energy where then you will feel like eating. So then when we implement the nutrition therapy, what we're trying to do there is to prevent any deficiencies or try to reverse them. Not always easy to do, but we still try to do that. We try to preserve the lean body mass and then try to manage the nutritional side effects. And ultimately, the goal is to maintain the nutrition status, all the while giving them a good quality of life. So oral food supplements. I think a big thing that I see a lot with especially the older children, are that it becomes a battle between the families, between the parents. Moms and dads, what we do is we feed our babies. And when you think of a child diagnosed with cancer, everybody's world's turned upside down. Back up. Everybody's world is turned upside down, and so the child or the adolescent doesn't have control over what chemotherapy they're going to get. They don't have control over the fact that they may lose their hair, that they're going in for surgery, that they're going to have to get radiation for 6 weeks. They don't have control over that. They do have control over the food that they're going to eat. And so if it becomes a battle about eat, usually the child's going to say, or the young adult's going to say, I'm not going to do it. So it becomes a real control problem there. So really encourage it. Encourage, not demand. Maybe favorite restaurants, cooking in the kitchen, preparing meals ahead of time, freezing them, that sort of thing. Adding calories. There's a lot of commercial products out there you can use to add calories. You can add, I think, cheese. I don't know that if cheese is bad on anything. It's a good way to add some calories. Butter, the same thing. Homemade smoothies have been a big hit at our institution. They've kind of become very popular here in the past couple of years, and so there's a good way to get some good nutrients and calories in that way. There's several protein powders out there, calorie additives as well, and then commercial supplements if you so desire. Another treatment that we've used for anorexia is appetite stimulants. We've had some really good results with those. Again, this can be for after therapy also. So the first one that I'll talk about is the Marinol, which is the synthetic THC. I have had really, really good results with that in my kids, usually older than 10. We've used them in children younger, but in the CNS disease, I'd like for the patient to be able to tell us or articulate if they're feeling funny or having any other side effects that could be confused for the brain tumor. The dosing, I think it starts at 5 milligrams QID is what the recommended is. I always like to start very low at 2.5 twice a day and work it up as the patient tolerates it. My very first patient that I tried on Marinol was probably, 8, 9 years ago. Hadn't eaten in probably 6 months a good meal, and was through with therapy, was getting ready to go home. We had to transition off of TPN, get them on an appetite stimulant, gave them Marinol. We actually went with the 5 milligrams QID after his second dose. He ate an entire rack of ribs and called 911. And he was feeling very funny, really couldn't articulate how he was feeling. So at that time we decided, we'll back the dose down to the 2.5 twice a day and go from there. He did not have to go back on TPN, thank goodness. The other one is the cyproheptadine or the periactin. It's an antihistamine, helps with itchy eyes, runny nose, watery eyes, and the side effect is appetite. I've had some really good results and have even done it as young as 10 months of age with some good results. What I like about this particular drug is that if you miss a dose, it's not crucial, and a lot of the patients will use it to kind of jumpstart after they've gotten chemotherapy. And then Megase, which is a steroid, is one of the appetite stimulants that works. It works very well. However, it's not without its own side effects, and one that we really try to steer away from at this point. I think the biggest thing is that it can cause cortisol deficiency, and then that just rears its own host of problems. So we do try to stay away from that one. There are occasions where after therapy, the patient has gone home and is unable to eat or eat enough, and that we will do a short-term Megase with a ramp. we'll start them up and then ramp them down over about a 6 weeks period. And then if we have to, of course, we have the nutrition support, which we try to avoid, but it's not always avoidable. We'll do enteral nutrition. My preference would be through a G tube, just simply because the NG tubes with the nausea and vomiting is hard to keep down. And then, of course, as a last resort, the parenteral nutrition. So now I'm going to jump gears and go into nutrition guidance after treatment. And at St. Jude, we have an ACT clinic, which is after cancer treatment clinic. And so I'm called to see patients over there primarily by the endocrine service, who also partners with the neuro-oncology service. And what I'm seeing more and more is the overweight aspect of the after cancer treatment. And it's multifactorial, but you think about the location of the brain. You've heard all the other members today talking about the sequela of a brain tumor and the treatment, and then you compound that fact with that exercise is not, they're not able to exercise as much or as frequently, or the fatigue sets in. And so I'm going to focus the remainder of this talk more on the overweight, obesity, and what we can do to try to help with that, or to try to prevent that. So. And this is not talking about cancer patients. This is just overall children. One out of 3 kids is overweight or obese in our country. That was a pretty staggering statistic as far as to me it was. I guess, again, I'm kind of skewed. I'm in a pediatric oncology hospital, so I'm not seeing the general public. However, I did my own little social study, and I went to our zoo. And I did not look at the animals. I just sat on the wall and I started looking at the people, and then I just geared it down to looking at the children. And I found the same thing. It was 1 out of 3, 1 out of 4 children were overweight or at risk for becoming obese. And that was alarming to me. Again, compound that with a brain tumor and all the treatment, and we've got a real concern. Not to mention the concerns of heart disease. We've got the liver, kidney, bones, all that to worry about. So this was from 2011, 2012. So 17% of children 2 to 19 years of age are considered obese in the United States. For the children 2 to 5 years of age, it's 8%. From 6 to 11 years of age, it was up to 18%, and 12 to 19-year-olds was 20%. I will tell you, the 2015 information is out. They have just not published it yet in this form. And I can also back up to say the previous study prior to this one, we have improved from 2011, 2012, so hopefully we'll see that continued improvement in the next. So how do we define obesity or overweight status? It's by looking at the body mass index. And I think what's important about the body mass index is it does look at your sex. It also looks at your age and your height and your weight. So it's not just classifying all children from 2 to 4, from 4 to 8, that sort of thing. They're actually looking at it specific to each patient or to each person. So they consider on the body mass index has growth charts. So patients that are people that are less the fifth percentile are going to be considered underweight. They do differentiate between overweight and obese. Again, there's different comorbidities that go along with each of those. So for overweight, it's anywhere between the 85th and 95th percentile on the BMI growth chart. Greater than 95th percentile would be considered obese. And again, this is for children and teens on this particular slide. So oncologic factors that are associated with becoming overweight or obese are, again, the tumor types. So central nervous system tumors are the brain tumors, what we're here talking about today. The craniopharyngioma, those patients, I probably most of my referrals are from craniopharyngiomas, and there's just not a whole lot that we can do with those particular patients right now. We're hoping on research and medicine to help us with these patients, but they've already got the short stature, and it's affected their endocrine aspects, so it's a very difficult, challenging case. Then we'll see the medulloblastoma later on in life and the astrocytoma. Again, the treatment modality, the surgery, whether or not they can exercise or not, the higher doses of the cranial spinal radiation, and then a lot of the patients have been on prolonged steroid therapy, which can affect also their weight as well as their bones. So then the late effects of the treatment that can also contribute to the overweight status or the obesity is just muscle weakness, ataxia, fatigue, unable to sustain long walks, maybe a foot drop, and then hormonal, you've got the slowed growth. The slide earlier showed how just the cranial spinal radiation can decrease your height. So that's another consideration. And then we have the good old behaviors of our children and young adults, and actually even older adults, is that we've got behavior, we've got TV, computer, video games, the dietary patterns. I don't want to go through all of these, but my next few slides, I just want to show you guys how, over the years, how food has changed as far as the portion sizes. So 20 years ago, on the left, a cup of coffee with sugar and milk was 45 calories. Today, 2 cups of the Grande Cafe Mocha with 2% milk is 330 calories. I mean, that's just so hard for me to believe, but we also wonder, why are we getting bigger and bigger as a society? 20 years ago, 2 slices of pizza was 500, now 850. Hamburger, look at the size difference, 330 calories versus 590, almost double. A bagel, 140 versus 350. And popcorn, 270 calories versus 630. And we think nothing of this to get this. And I don't have the French fries and Coke on here. Okay. I thought this was interesting too. Although nearly 3/4 of consumers agree fast food is not good for you, 8 out of 10 go at least once a month. And we're all guilty of it. We live a fast-paced, fast lifestyle, and that's just easily accessible, but it's not the best thing for us or our children. And this was another study that was done that said 77% of children aged 9 to 13 participated in free time physical therapy, physical activity 7 days before this survey. So they weren't talking about yesterday or the past days, they were looking at a week ago. 29% of high school students participated. So the younger, the 9 to 13, actually did more participation in some kind of free time physical therapy. And then 15% of high school students had not participated in any kind of physical activity. I'd love to know where this study was done, because I think you could do it in my neighborhood or my section of Memphis where I live, and I would beg to say that would be even higher. So what can we do? I'll run through this real quick, and I was going to let everybody know, back in the back left, there's a table that I've got some MyPlates for anybody that would be interested in having one, and some recipes, some low-calorie recipes. So on the food plate, basically the red is going to be the fruits. We know we need to eat more fruits. The dark green leafy vegetables. Try to get the brown rice and the whole wheat. Try to stay away from the refined. For the dairy, try to do the fat-free or low-fat. And then we've got to incorporate more physical activity. Good way to do that. They're talking about get the printer closer. I'm talking about moving it further away. Take advantage of all those things. In the parking lot, try to park farther away and walk into the store. At the grocery store, walk around the perimeter. Those are going to be your healthier food choices. The phytochemicals are just natural foods that have antioxidants that are good for all of us. And then here it breaks it down for men, women, and children on how much to eat. Fruit, on average, we need around 2 cups a day. Vegetables, 3 cups. Grains, anywhere from 5 to 8 ounces. Protein, 4 to 7 ounces. Dairy, we need about 2.5 to 3 cups a day. And so basically, this is just to summarize. The American Cancer Society says we need to eat more healthful foods. We all know this. This is just kind of recapping. We need to eat more fruits and vegetables. Choose whole grains. Try to limit the consumption of processed and red meats. And try to maintain a healthy weight. Even if you're overweight, it's best to lose a little bit of weight than to not even attempt to try to lose any. And then for the benefits of regular physical activity, not only does it make you feel better, but it also maintains healthy bones and muscles, and it can reduce your risk of obesity, future cancers, diabetes, high blood pressure, and also can help with concentration. So a lot of good reasons to do it. So summarize, choose wisely, compare nutrition information on labels, watch your caloric intake. Portion sizes are very important, as I pointed out, and try to maintain a healthy weight. If you're not at a healthy weight, try to get there. Even small steps are better than none. and incorporate daily physical activity. So, thank you.